This means that health service providers may have to consider a reciprocal and cross-cultural diabetes education in terms of diabetes management among culturally and linguistically diverse people at individual level. And the most important aspect for health education was to understand the motivational factors for that particular individual to look after his or her diabetes. Now, as per diagram, we will explore how diabetes literacy does affect on diabetes management among culturally and linguistically diverse individuals. However, prior to that, I would like to put a little light upon health literacy in general. The World Health Organization has attempted to define health literacy as the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. Again, by USA Department of Health and Human Services, health literacy also used to be understood as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Nutbeam in 2000 proposed a model of health literacy that includes 3 levels of health literacy: functional, communicative, and critical literacy, where functional literacy was considered as the basic level of reading and writing skill that allows a person to function effectively in everyday situation, and communicative literacy as the advanced skill that lets someone to extract information and meaning from different forms of communication and make the information effective to changing circumstances. And critical health literacy is the ability of a person and a community to address the systematic factors that affect their health. Hence, these definitions acknowledge the fact that health literacy operates within a complex group of reading, listening, analytical, and decision-making skills, and is dependent upon the ability to apply these skills to health situations. However, there is criticism of health literacy for the way it is defined. Smiley, Williams, and Cooper pointed out that health literacy confined as a skill set of a person's ability to read and understand medical information, and it assumed Western socio-cultural context, which is apart from socio-cultural realities of that individual. We also know from the literature for many years that literacy is constructed and enacted within social, cultural, and political context, and therefore it should not stand alone as the general literacy and numeracy skill in order to improve health literacy. It should be integrated with the socio-cultural context where the consumer belongs to. Now, what literature tells us about the relationship of health literacy and chronic disease management? Limited health literacy is associated with poor self-care for the chronic disease like asthma, acute immune deficiency syndrome, hypertension, and diabetes. In 2006, the Australian Bureau of Statistics conducted the first National Health Literacy Survey as part of the Adult Literacy and Life Skills Survey. This health literacy survey demonstrated the extent of poor health literacy in Australia and indicated that people with the poorest levels were generally older, lacking formal education, unemployed, or their first language was not English. In 2001, Clalit Health Services in Israel conducted a diabetes study to demonstrate the potential to improve in all 3 types of health literacy: functional, interactive or communicative, and critical among diabetics and other chronic disease patients. The researchers suggest that healthcare providers needed to consider where the patients were getting information, whether or not that information is reliable, and to inform the patient the best source of information. Then in 2004, Kim and Love conducted a study to assess the association of health literacy with self-management behavior in patients with diabetes. They found that diabetes education was effective in improving diabetes knowledge, self-management, and better control of blood glucose among patients with both limited and adequate health literacy. Therefore, Black, Innes, and Chopra defined diabetes literacy as the skills and competences to comprehend, evaluate, and use information to make informed choice about the risk, prevention, and management of diabetes. Finally, researchers remarked that exploring a patient's health literacy levels may provide a better understanding of the patient's potential barriers to self-management of disease and health-promoting behaviors. This means they suggested an interactive learning process is required between patients and health service providers. Health service providers need to understand patients' health belief, disease perception, constructed by his or her socio-cultural background, and as well as teach and inform the patient the dominant culture and its ways of healthcare service. From this analysis of the research literature in the field of diabetes management and diabetes literacy among culturally and linguistically diverse individuals, it can be suggested that healthcare practitioners working with such individuals may benefit from partnership with adult literacy practitioners, particularly teachers of English for speakers of other language. Accordingly, multidisciplinary research can be conducted between health and education sectors to explore the concept of reciprocal knowing and adult learning pedagogy for collaborative diabetes education in the Australian context. Thank you very much for listening to me and for giving me the opportunity for sharing my knowledge with you. If you are interested in this topic or if you are researching in the same area, please feel free to contact us in the email addresses provided here. Thanks again.